Welcome, and thank you for coming, both in the room and on the VC. Um, this was organized very impromptu. I got an email from Alice, who had met Kurt on a trip to Haiti recently, and said, "Oh, Kurt's going to be in town on Monday. Can we organize a tech talk?" I said, "What a great idea!" And so here we are. And from the perspective of Google Health in particular, which is in some sense the host, uh, this is particularly interesting because it's outside of the normal zone of what we think of as a health project. It's not part of the PHR. What exactly is it? Who knows? But I think it's important and sort of deeply related to the overall health mission. And I think one of the reasons that I'm sort of encouraging all kinds of conversations is to sort of broaden and expand our thinking of what health really is all about. So with that note, Alice, to introduce Kurt.
Thanks. So as Mark mentioned, I actually was on a trip to Haiti a few weeks ago, and I was there with some friends who know I'm a software engineer, I love technologies, and they told me, you cannot leave Haiti without meeting people from solutions. So I say, okay, so, who are these people that, everyone is excited about? So I went to the office and I met them. And Solutions has been created in 2001 by 4 engineers, and Kurt was one of them. And these engineers have this vision for the country where they say, new technology, we can do something with new technology in Haiti. Even if the situation is complex and hard in Haiti, new technology can really be the vision for the country. And even if right now new technology are not very well developed, it's actually maybe an advantage. Maybe, because there's nothing right now, we can go wild. Everything is open. We can decide to do things however we want. So it's very open for new ideas, for innovations, and this is pretty much what Solutions is trying to do. So right now, there's maybe 20 engineers, if I'm correct. And today, Kurt is going to talk more about a tool they developed to monitor HIV in Haiti, and what are the challenges and the results that they have. So thank you, Kurt, for stopping by in New York and giving this talk for us.
Thank you very much for your introduction. My name is Kurt Jean-Charles, as Alice told you. I am the co-founder and the CEO of Solutions. It's a company that we've built in 2001 and who's offering custom software development in many different areas. And I've met Alice back in Port-au-Prince. We spent 10 minutes maybe because she had met my other partners, and we had a very interesting talk about the project that we are doing in the health system in Haiti, and more precisely with HIV. So I'm going to give you a little idea about what we're doing. I'll try to do it in less than 40 minutes so that we can have time to ask questions, discuss together, and share some ideas. We have actually, less than 20. I'd really like to have 20 engineers to have more fun in Solutions with me. We are 15, and we are, we are very passionate people that really try to get themselves into what they're doing and do it with a lot of passion. So I'll going straight to my presentation here. I won't give you a lot of slides. I'll try to give you a little demo of the system that we have built in Haiti. So before that, I want to give you some quick facts about Haiti, just to know where we come from and what are we doing in this kind of environment. We'll talk about the MESI project in Haiti. MESI is for Monitoring, Evaluation, and Surveillance Interface. Regarding what we had in health information as a health information system in Haiti, what was the basic battle plan, the basic vision when we started back in 2004, 2005, and the actual implementation, what we had as challenges and what really worked and what didn't work at all. We'll also talk about the next challenges that we'll need to face in the health information system in Haiti, and then try to get the last 20 minutes for question and answers and other interesting points that certainly you'll have to share with me. The Haiti quick fact sheet, I won't try to invent anything. I'll try to reuse as much as possible. So you have the link from Wikipedia. Let me try to find it. Wikipedia here. Oh, okay. That gives you basic information, basic fact sheet about Haiti. The capital, which is the largest city, a population of more than 9 million people, 27,000 square kilometers. The capital, Port-au-Prince, with more than 2 million people in it. And one of the more challenging countries, I won't say the poorest country, maybe it is, but it's one of the most challenged. Well, it's a country where we have a lot of challenges, and it's difficult to find that much challenge in the northern hemisphere. And so you have a GDP of per capita of $570, which is not a lot, and very serious situation difficulties between a lot of people that do not have access to information, access to basic infrastructure, health, and any kind of infrastructure that should be taken as granted. So this is basically a country where the official languages are French and Haitian Creole. Most of the population speak Creole, and we have been it's been more than 200 years since this country is independent. So it's been a lot of there's a lot of history, a lot of very interesting culture aspect in Haiti. I'd really encourage you to maybe go further on the web and see what's going on there. And I'll also give you an idea with some basic figures I took from for example, for the World Bank. That gives you an idea of the economic and social context. And it's also interesting because it gives you it gives you a comparison between Haiti and the other countries in the Caribbean for many different aspects. For example, economic and social context. You see, this is the line for the Latin America and Caribbean region, and you see how Haiti is performing for this. You see also aspects about telephone lines per 100 people. In 2000, we have 0.8 people with a telephone line, and in 2007 it was 1.1. But one thing very interesting, you can see that, for example, in 2000 we have 0.6 for 100 people with access to a mobile phone, and it changed a lot since 2007, and you can see how this line really got a lot of improvement in basically the last 2 to 3 years if you look at this figure here. So in Haiti, it's basically a population where you have more than 30%, more than 35% of the population in 2005 that had less than 15 years. So it's a very young population where you can have a lot of opportunity to create a totally different countries, but it's also a risk if you don't take it accurately. So many people are trying to think to find new way to be innovative, to not only in for technology, but for many areas to try to come with and another vision, another way of envisioning the future for Haiti. And that's also what we're trying to do in solutions, well, in the technology part. So that basically gives you an idea. I'll share this information with you about the facts in Haiti. I'll also try to take this tables. This gives you an idea of the AGI. AGI is an indicator that was used by UNDP to evaluate human development factors in many different countries. So this gives you an idea where Haiti stands up compared to many different regions or many different countries. So this is basically a country that is at the same level as other countries that are in Africa in the sub-Saharan area. And this table gives you also some idea of the positioning of Haiti concerning the many specific factors. For example, in 2005, Haiti was in 146th position, while Iceland was in the first line, and you see the difference of this. You can see also the life expectancy, which is, well, actually it's 16 now. It's improving. That's good news for me. And also the revenue that is unfortunately it's going down, but we're sure that somehow it will improve in the future. You can see also the human poverty index, adult illiteracy, people without access to water, children underweight for age. So these are kind of indicators that are very it gives a lot of headache if you can take it like this. So these are some tables just to give you an idea of the population. I should tell you, as we're going to talk about information system and things, that you have to keep in mind that it is a country where we have very low access to infrastructure. I mean, road access, not even talking about electricity access or broadband access and things like that. So you have to imagine a country where, for example, in the capital, we have less than 12 hours of electricity in the metropolitan area. So you have a lot of areas where there's basically no kind of services as water or electricity or internet. But we had a very interesting success stories with mobile telephones. For example, you've seen how the population got into this very quickly, and this is the same trend we are sure that can be used to improve many part of the life of the everyday life of people. 10 years ago, you had places that were totally not connected to the rest of the world. Well, today they are still not connected because they do not have the road, but you have people with their cell phone that can have access to anyone in the world. This is the first step. We'll have other steps to do with building roads, providing broadband access that can, all kind of activities that can connect people and give people access to new opportunities. So this is the kind of way that we see the future. We try to envision better days for the future. So this was to give you a basic idea. I'm certain it's not complete, but that gives you an idea of the project. So of Haiti. So I'll get back to the main point of the talk, where I wanted to present you the monitoring and evaluation project for HIV. First, I'll have to talk about how the health information system was in Haiti when we started. We started in 2004, and we had basically an information system which was paper-based. I must tell you that maybe in the 70s, there was a very important structure in the public health system. There was motivated people, and they have succeeded in building an information system that worked. Without technology, it worked. And when we started to lose the people that were involved in creating the system, we've lost all the know-how that they had, and all the 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 capital that they build with their drive and their vision. Uh, so you had basically a lot of investment, mainly in HIV programs, where many people were concerned by the fact that the level of infection was very important in Haiti. So we had a lot of investment in this area. But everybody was concerned because it wasn't easy at all to actually measure what was going on really, and how the money was used, what was the effect on the country. And every time that you had to provide a report, it was like a very important project to launch something on the moon or something like that. And it took, for example, more than 3 months, from 3 to 6 months, for example, to go and gather data to every site that were providing services in HIV. As I told you, the roads are not very good. Sometimes you have to go to some places where you have to walk many hours because your car won't bring you there. You have to walk many hours and get to the site, get the information, get back to the capital, have someone compile this information, is an own box, is an own system, and eventually share this information 6 months or 8 months later with people that were interested. So that was basically the kind of environment that we had. But we had the chance that people they were concerned by this situation, and they had put in place a mechanism using data collection tools, paper data collection tools, to collect data and provide reports after that. So we started with what they had as a system. What we wanted to do was to first try to provide aggregate data that could be useful to give a clear picture of what is going on for people that had to make decisions, and for people that had the responsibility to improve the system and be accountable for the money that the country was receiving. So we started from this point, and today it is we had a very interesting projects where all the sites that are providing services in the HIV areas are connected to the electronic system, and all the sites that are providing HIV care, HIV drugs and things like that also are using an electronic medical record, where mainly at 90% or more patients enrolled in HIV care have their own electronic medical record. So and now we are one of the country. We are also one of the country of the PEPFAR program. The PEPFAR program is an initiative launched by the United States to finance HIV activities in many countries in Africa and in Haiti. And we are one of the countries in the PEPFAR program that can accurately provide good reports on a monthly basis. So the basic battle plan that we had when we wanted to launch this project, it was to make sure that we can build something that can enhance public awareness and improve data analysis capacity for the people that had to make decisions and that were accountable for the money that was injected into the system. It was important to build a reliable system that would work with no possible excuse. Don't forget that we are in an environment where you do not have electricity, you do not have the best access to internet, and you have a very high level of illiteracy. So I won't even talk about access using computer. And we needed to make sure that the service that were provided at the health facilities wouldn't be disrupted by anything that we wanted to introduce as technology. We're not doing technology for technology. And we also needed to build a scalable system that could be reused for other health areas. And it was very important for us because there was a lot of resources for HIV, but there is also a lot of concern for other areas in health in Haiti. For example, I think Haiti is one of the last countries where many people are dying from malaria. And so we need a system that could be easily used by any other kind of health information infrastructure that could be needed. So that was the idea behind this. I'll show you very quickly what we've done. And for the first point, enhance public awareness and improve data analysis capacity. It was, I think, a very bold move because we decided to put any non-sensitive data. We decided to put it available to anyone. So anyone who can have access to the internet can see actually what is going on in the HIV service in Haiti. So I'm giving you. Okay, so if you type www.mesi.ht, you'll get this to this website here, and we try to put as much emphasis as possible to the report and to any kind of information data that you can gather from the system. So if I go quickly to the reports, I have reports that I can show, like tables, and I have different areas, different services that are provided for HIV, related to HIV. For example, it's actually in French. I told you the language, the official language was French in Haiti. But PTME is for PMTCT, it's a program to prevent transfer of HIV from the mother to the child. And we have another area like VCT, is like voluntary counseling and testing. So we have basically different areas where you have a specific set of reports that are available. For example, if I go to VCT and I want to know how many people are tested for a specific period in Haiti, I can go to this report and have it available and make some analysis at different levels, because we try to provide a transparent system for the site at the site level, the unit that is providing the care service, at the regional level, to know what is going on for a whole region, and also at the national level to build the national awareness. So if you look at this, report here, you see, for example, number of people tested, and we've launched the system in 2004, and you can see how the numbers have improved in many years. We started with 58,000 here in 2004, and now we are more than 450,000 people that we have tested for 2008. So you can see with one trend, you can see how to analyze it. I can choose another report. All the reports use basically the same approach. If I go there, I want to see the number of pregnant women tested and HIV positive. You see, I can have this view where I see all the information for a specific period. There, I've chosen October to August, and I can see all the institutions, how they are performing. This is actually the number of pregnant women that have been tested in this site for this period. And this information is public. So if I have health managers that want to know exactly what is going on in their area, they can do it side by side, and they can do the analysis even side by side. So I have this kind of table here where I see all the sites. Of course, I can choose my own parameters, choose the period, choose a specific region, or choose a specific set of health providers. But for each of them, I can click here and see the trend of the specific indicator that I'm following. For example, it's interesting to look at this kind of graphs, because you can see how the level of service offered by the site for a specific indicator. For example, if I'm trying to see what is going on for pregnant women in Haiti, I should ask myself, for example, what happened in March? Why did we have such a drop between 2 months? And you'll have person, well, I've learned a lot meanwhile, and you'll have person that could easily interpret that, for example, in March, this is the carnival time. You have people that a lot of free days, and you have people that are leaving the area to go in other places. So you have less days of services or things like that. They can interpret, and they can figure out maybe we should add some more staff, or we should change they have the ability to take decision, and that is the basic thing that we want to provide with this kind of system. We have also the possibility to see all the reports that this specific site have provided for the period. For example, if I want to make more analysis, I just have to click here, and I'll see for this site all the reports. This is I'll get back to it to show you that all the reports, all the information that are available on the site are in fact collected from the health facilities that provide a monthly report using the internet every month. And I can see there all the aggregate report that this site are providing. So I can actually look at the whole report for each month. We've chosen from October to August, but the last information available is from July. And this gives a larger idea of what's going on. I can do the same analysis by region, because Maybe someone who has to make some decision at the central level doesn't have to go side by side to see what is going on, but it's very important for this person to be able to see what is going on in the region. And there we take the same basic approach where we use all the reports that are the aggregate report that are given each month by the sites to compile the information by any kind of aggregation. For example, here for regional information, we can do it also by health networks or by specific health facilities. And there, for example, I can make the same analysis at the site level that I can do at the regional level. For example, I can see the trend for the specific indicator for the period I've chosen. And with this, I can have many different kind of analysis that I can make. For example, if I want to see how if I want to analyze only one specific indicator, I can see graphically the mean, the median, and the standard deviation and things like that for one specific indicator and make some more analysis and finally take some decision for the future and see actually how the decision is impacting the reality. So you have all the reports. If you understand how one report works, it's the same for all the reports. We also try to provide the same visibility, access to information using maps. And this is one thing that we're working as a prototype to see how we can use, for example, Google Map to do that. Now we're not having Google Map yet, but we can provide this kind of, for example, for if I want to see information about tests provided for the different regions, there I have the country and I see the different regions, how the testing is distributed. And I can click on one region to see, to have access to more detail for this region and see, link it to other kind of geographical information, for example, where I can see the location of the sites, I can see the roads, and I can see, compare the level of access to other kind of information like population, like infrastructures and things like that. So this is basically open to everybody. I didn't have to enter any access code here. There's also an interesting part. This was a little tricky also. We still wanted to make sure that everybody could have access to this kind of feature, is the fact that you can actually see all the site who's late in for data collection, who's providing data with errors, and you have this kind of tables, for example, here, where I have for one department. Let's say I'm responsible in one region, and I want to see if everybody's on time, if everybody's providing the reports correctly. I can go to this to this screen and see exactly that, for example, this institution hasn't provided his report for the last 2 months, and I can compare it to other kind of institutions. So that means there you have a tool that can empower people to make some follow-up, to know exactly what's going on, and to be able to take some action about what's going on. And this is for example, we have many different data collection tools, and all this is very flexible in the system. You can easily add a new data collection tool or modify an existing data collection tool and have this kind of monitoring screen as we call it. So this is very interesting because it also helps see the status of the data collection with color codes, and also the forms that probably have some error on them. So you see, for this department, there will be definitely a validation session where people will go actually to the sites and verify what's going on at the site level. So all this is open and is available. These are non-sensitive data, non-sensitive because they do not concern private information or personal information. They could be sensitive because it's really important for the site performance, but making it public makes them more responsible, makes them more responsive also, and that was an important point for the system. The other part, so this is where you go to actually see the data. The other part of the system is actually the people that goes to enter the information. So I'll try to log in as user at the site level. There, I definitely need to get a username and a password, and the security, the definition of the users, link the users to their specific sites. So once they enter their data, they are directly they go directly to their own area, which is secured, and where we are sure that everybody is responsible for the data that is provided on the system. So the person who's entering the data sees this kind of screen. He has his pending reports, and for the pending reports, he has all the areas that he should be reporting. And if I go to one specific area, you see the function is very simple with two buttons. One to edit and save, and the other to validate the data. So the principle is very basic. They had to do the same thing on paper before. Now we're asking them to do it on paper, but also on the electronic system. These are non-sensitive data. It means that, of course, we try as much as possible to make sure that all the sites has electricity, they have access to the internet, but we are also trying to build a system with no excuses. So if you do not have electricity, if you have a problem, well, you'll put this on your piece of paper and you'll go to the nearest internet shop, or you'll send the paper to the nearest regional office. So you have many different way of providing your report, but you are responsible, and that's the basic thing. That's the basic thing that we're trying to promote to the system. You are responsible for the data that you're providing. So this is very simple. I just click on the edit button. So for this user was linked to a specific site, so he doesn't have to choose which site he's going to work for, which report he's going to use. All the reports is automatically generated on a monthly basis. For example, if the site is providing testing and counseling, you will have access to the testing report. If the site is providing, for example, drugs for HIV patient, you will have access to the and all this is managed at the central level. So it's very easier to make sure that everybody has access to what he can actually do. So you just have to click on the edit button and then make the changes and then save it. Okay. The system is also configured to detect some basic errors. For example, the number of people HIV positive cannot be more than the number of people tested. It would be strange. So we have this kind of simple analysis that is also done basically by the system. And then you have someone entering the data and saving it. It's very interesting because when you save it, it's in one database. It weren't used to that before because each region has had its own database before. We're trying to have one single database now. And the second button is very interesting because it allows them, if you are not, if you do not have to fill the report when you have all the information. You can start to fill your report and then keep it in your area. But once you have finished with your reports and you click on the validate button, it's like what they had before. It's like the fact that you take your report and you send it to another level. So if you send it to another level, you cannot make changes to it anymore. And this other level will have to make some analysis, some validation to approve it, or return it to you if there is some error. It's also important because they won't change your data because you are responsible for your data. If they detect that something is wrong, they'll send it back to you to make sure that you can provide some comment. And the comment is also interesting because I can actually add a comment for each information that I'm entering. So it's also interesting to have meta information to the actual numbers that you are entering, and you can share this kind of comments between the validation level, at the regional level, at the national level, and at the site level. So all this also stays in the database. So. So this person, I entered as a person who has only access to data entry. So you can only see the pending reports and the reports that have been rejected, returned because someone at the validation level found that there was something wrong with the report. So it's basically only when we're training these people, it's basically training them to know how to use these two buttons, and it goes very fast. And we want to make it as simple as possible. I will now log in as an administrator of the system. I won't have time to go to spend a lot of time under the hood of the system, but we wanted to make sure also that it was as much flexible as possible, and all the data collection tools, even all the reports, are things that an administrator can design in the system. One important thing also that we have learned in building and in putting in place the system is that we wanted to make sure that we were asking the people at the site level, the health providers, to make the list as possible, because it was definitely adding to what they had to do before. And for example, this led us to consider the opportunity to link our aggregate data system to the EMR system where all the patient records were maintained, so that the electronic system could generate the monthly report by itself. So then you wouldn't need someone to actually go and spend some time computing the aggregate reports. And it can also be used as a comparison system between comparison and a validation system also. So I'll well, we're running out of time. Today we have more than 150 sites for HIV, but what we're trying to do now is trying to use the same system. You see, it's basic, to expand it to more things. So that will mean that much more sites will have access to this, and we could use it for. We're launching something for TB and malaria. So we'll have 3 health programs, and then we will be able to expand it a little more. Not all the sites had them. We had, I think, less than 20% of them with the capacity, actually. But we started also with the fact that we needed something that would work even without it. Of course, we had succeeded in providing all the sites with the environment that was needed. And I must tell you that this project was piloted by the CDC office in Haiti, and they've put a lot of effort in creating the environment, providing electricity, providing internet access, and it has been a whole machine. But we also keep in mind that it does have to work even without all this access to technology. Yeah. Exactly. Or he goes to a an internet coffee shop, yeah, internet cafe, and he can enter. Or he can go to the regional, and they have many different way to do that. I think that we're running out of. Sorry. We started in 2004, and we started to gather the first set of data at the middle of 2004. And well, it has evolved a lot since 2004. We had a lot of new features and a lot of. We also learned a lot, and we could be more efficient. I think that we're running out of time. I see there that the 1 hour is almost gone. So I'll go quickly to say that we have basically a system with many different layers. This is the layer where we are manipulating aggregate data. There are other layers for the electronic medical records where we have more than 90,000 individual medical records in Haiti. We are also trying to introduce, well, it has already been done, case notification for HIV, where we have a unique, a central database where any HIV case detected is reported to. And we are also building all this kind of infrastructure to make sure that we build a consistent system, keeping in mind that we have many challenges like personal identification. How do you make sure that you can identify the person? It's maybe basic, but we have 50% of the population in Haiti, or maybe more, that is not identified. And we have also all different kind of challenges where we can improve the system and make sure that it is much more available, much more easy to use, and much more interesting, much more efficient. So I'll stop there just to make sure that we have enough time to get some questions, maybe from people that are not also in the site with us.
Right. So people on the VC, if you've got some questions, please pipe up.
Hi, I've got a quick question. How does this stuff integrate with projects like OpenMRS or DHIS?
Okay, that's an interesting question, but because it's been challenging for us. We have basically 3 different EMR systems in place in Haiti, and one of them is the open is really an adjusted version of the open source system. And to build the case notification, as most of the people who are receiving care for HIV now have a medical record, We're trying to build a layer on top of the EMR for the case notification, where the EMR sends electronically the case notification to the national database. We use for this the HL7 standard to communicate between the EMR and the new layer that we are building for case notifications. And we also we're also using HL7 to share aggregate information from the EMR, and each team working on a specific EMR develop the specific reports that we need on a monthly basis to send it in an XML file format to us.
Other question from remote sites? Questions in New York?
So I had one question. You talked about, bringing up having all this aggregate information eventually lead to like a change in the policy of these people, or create a sense of responsibility for all the like the different stakeholders, as well as have a place where it's all aggregated so that people who are able to affect the policy changes are able to make good decisions. Is there a way for you to see whether that's actually, actually that's like playing out the way you imagined?
Well, I must tell you that we didn't. We took a lot of time to build a trend around the system, and to actually have the people understand that it is an interesting system at the national level. We had a strong involvement in the management thing, to make sure that you have follow-up, to make sure that there are at each region and for each site, basically someone who's responsible to provide the information, and also at the decision level, someone that at least goes to see what is going on, and can see in the trend for each indicator what must be improved, and actually measure at the end of each period what went wrong and what was good. One interesting thing that I didn't have time to show in the system is that there is also a performance analysis schema, where at the beginning of the year each site has to define his objectives. And they do that with the decision makers at the regional level and at the national level. And then with this system, you can automatically compare what the objectives with the results, and you can have discussions around real facts. And this is, I think, one thing that helped change a lot the perception of the system. Of course, well, it was easier at the aggregate level than at the EMR level, but at any level we try also not to disrupt the normal activities that you have on the site, and we use the people, the resources that are available. But we make sure that they understand that introducing this or that makes them work better, make them more efficient in what they have to do, and we also try to listen to them also, to understand what works and what will definitely not be acceptable. And we've had this kind of issues in the last 4 or 5 years. So we've adapted a lot. We've learned a lot from the technology part, and we succeeded in having enough with learning from them and building something that was really adapted to what they needed. So we were only enablers, not people that were coming with a way to work, a new way to work. That definitely wouldn't work.
Then I have one last quick question. At the beginning, you said, you mentioned that actually when you started your project in '04, there was almost no cell phone, and now we went up to, I think you showed 28% of people having cell phone. Could you use it as a way for people to enter the data?
Yes, we're actually thinking about this, how we can use, well, two aspects, how we can use the GPRS facility for network access and for access to the internet, because it costs a lot to provide the access to the internet as in very remote location. Now that we have a good coverage with the cellular, this is one thing, how to use the GPRS to access the internet. And second, how to use the phone itself to provide either a help desk facility where you can actually call and talk to someone, or send SMS or other a kind of communication using your cell phone. So this is definitely a way that we want to explore.
Reflecting back on starting the project almost 5 years ago now, or more than 5 years ago, if you were doing it over, what would you do differently?
That's a tough question. Maybe the first thing that we didn't figure out at the beginning was that we had to make sure that the system was as much flexible as possible. When we started, we thought that the data collection needs, they were fixed and they wouldn't change. So we built a system with the data collection tool that were provided. And when the first time they called us to tell that the data collection tool has changed, well, it was tough. But we took a good lesson from that, and we've tried to build the system as much flexible as possible. So we have many parameters that we can change and adjust to make sure that the system fits any kind of situation that you can imagine for aggregate the data collection system. There's also maybe we are very concerned about the performance, and we are actually seeing, well, from the technological side, how we could improve the performance of the site, and also improve the data usability, make it more user-friendly to people that are not into the system. And this is, well, basic challenges that we'll have to face in the next months.
Thank you very much. That's fascinating.
Thank you very much. It's been a pleasure.